Tõesti. Test. This is a test for the live stream. Can you confirm sound? Just a minute. Okay. What is the... Matthias is going to... Is he going to pick Jan de Waal?
I know he was phoning in, but I don't know.
Just one more minute. We're about to start. I think there are about 50 people following the live stream, together with 40-something here. So means a good ground for the discussions later on. Professor De Waal just arrived. We're uploading his slides. Yeah. Zodat de mensen hem de livestream een beetje kunnen. Just give that a
Zo, goedenavond iedereen. Welkom op dit symposium. Ik ga direct, Ik ga direct van taal veranderen, omdat we weer een internationale spreker hebben, Professor Mervyn Singer. So, good evening everyone, and welcome on our nice symposium on antibiotics. It's a very hot topic in actual daily clinical practice, and so we want not withhold you this nice topic in our postgraduate course. You're not alone tonight, because Big Brother is watching you, and some other people too. So we are live stream online on a YouTube channel, international. So welcome to our online listeners. So we have two excellent speakers tonight on the field of antibiotics and more in reduction of antibiotic use. But first, there will be a shortly introduction by my chief, Professor Malbrin, who will give a fly of time in the treatment of sepsis. Thank you very much.
Okay. Thank you, Matthias. Ladies and gentlemen, welcome to our Antibiotic Stewardship Symposium. I will just give a brief introduction to set the stage for the next speakers, Professor Mervyn Singer from UK, London, and Professor Jan de Waal from University Hospital in Ghent. So we had the pleasure to welcome Mervyn Singer this morning in our ICU. And we gave him a white coat, and then he gave an excellent lecture on fake news in sepsis. But this evening he will give a lecture on how to reduce antibiotic burden. After his lectures, we rearranged the tables, and then he participated in the multidisciplinary discussions of all the patients. So this is the program of today. It's just yes, I will give the introduction. Then Professor Mervyn Singer will tell us all about how to reduce the antibiotic burden, and Professor De Waal will talk about antibiotic therapeutic drug monitoring, and I will have a round table discussion, and we'll see whether there are any questions arising from the people who follow the live stream. So tonight will be about breaking some bad habits regarding the choice of antibiotics, the dose of antibiotics, duration, and the escalation of antibiotics. We all know that sepsis is a major killer, and these are the figures that Mervyn showed earlier today regarding possible or potential fake news. In the US, around 258,000 patients are supposed to die of sepsis every year. So sepsis kills, but we have to put this in the right perspective. And maybe this could be one perspective where you see that the deaths from sepsis are higher than those from cancers accumulated. If we look at the evolution of sepsis mortality over the last decade, you can see in the red line is the US and the blue line is Australia, and the arrow is after the introduction of the first surviving sepsis campaign guidelines. So you see that there was a historical trend which doesn't seem to have changed over the years. If we look at the historical mortality in the US, around 40% in the year 2001, and this is the dotted line, and this is the results of the landmark paper, the RIVERS trial, looking at goal-directed therapy in patients with early sepsis. You can see that the mortality in the goal-directed therapy group just equals the normal mortality of the average population in the US, whereas the standard treatment group has probably an excess mortality. So the orange ones should be at the level of around 40%, which could raise some questions. Situation is important because we as doctors and clinicians sometimes are fighting against industry and politics and maybe insurance companies, especially in the States. I could say to you that I have no disclosures with respect to this lecture, and this was the case for the co-authors of the first Surviving Sepsis Campaign guideline published in 2003, which of course is not the case. I have some conflicts of interest, so I started here 2 years ago, before I worked in Antwerp, and I'm one of the co-founders of the Fluid Academy and of the Abdominal Compartment Society. So conflicts of interest, I think, is important when we as caregivers or scientists or doctors give lectures, and this was not done during the first publication of the guidelines. And one of the major companies that sponsored the guidelines, this is the evolution of the shock stock shares over the years, and you can see that there may be some influence there. So I don't want to talk about politics, but when it comes to treating patients, sometimes there is a mix of science, evidence-based, politics, of course, industry and money is important, and some of us really do have some religious beliefs. So one could say that all this is fake news, but let's have a look how this all started and where did it go wrong. It started with the death of a young boy, 12 years old, Rory Staunton, in the state of New York, who got a wound after a basketball game, went to the hospital, went back home, and then later on had fulminant shock, and he died. So this was in the year 2012. So why did the death of a boy prompted new medical efforts nationwide? Because via relatives, the government Cuomo of the state of New York announced a new law after this tragic death. And this was in 2013. And the politicians believed that by early detection of sepsis, they could save up to 8,000 lives just in the state of New York. This was then taken over by the Healthcare Association of New York State, who were committed to improve sepsis care and outcomes. And they filed some regulations that doctors should adhere to, following the components of the National Quality Forum number 500, which states that doctors need to be complete within 3 hours to measure a lactate level, obtain cultures, administer broad-spectrum antibiotics, and some fluids at 30 ml per kilo. And then within 6 hours, they needed to complete other items to start vasopressors, and in the event of persistent hypotension, need to measure a CVP, mixed venous oxygen saturation, and remeasure lactate. So then in 2014, this was taken up by the Centers of Medicare and Medicaid Services, connecting this adherence to the bundle to financial support for the hospital. And it reads as this: so payment is determined for the hospital if they adhere to the National Quality Forum bundle under number 500. So I then looked it up at the website of the NQF, the National Quality Forum, and I found that there is this advice for treating patients with severe sepsis and septic shock. And if you look very well, you can see that the stewards or anyone can submit a bundle or a guidance to the National Quality Forum, you can see that the steward contact information goes to Henry Ford Hospital and then goes back to Manny Rivers, who was the first author of the river study in 2001. So this seems that there is some conflict of interest maybe between research, politics, insurance and money. This is then taken over by the industry, where you can see websites. This is in 2018, and combining the political statements with a strategy to fight sepsis. And also on the Rory Staunton Foundation, you can see that there is a lot of industry involved. So I apologize for mixing politics with science, money and religion. But I think it's important that we realize what you read may have a connection with other issue. So sepsis is a continuum. And in 92, the first consensus definition by Bone defined sepsis as a continuum between infection, SIRS, sepsis, and severe sepsis. That was 1992. So maybe it was time for a change, for a new definition. And this came out in 2016, where Mervyn Singer was the first author of the JAMA paper, stating that sepsis in 3.0 definition is infection plus organ dysfunction. Mervyn will say that sepsis is just bad infection. Okay, right. And organ dysfunction can be assessed by a quick SOFA score looking at the impact of sepsis on distant organ function. So let's go back to what happened with the initial consensus definitions of the Surviving Sepsis Campaign guideline and the bundles. So the initial 3R bundle stated to measure lactate, cultures, give antibiotics, and to start rapidly infusion of 30 ml per kilo. So lactate, if you look at the statement, there is not much data to support this, and some, especially on Twitter, state that there are some religious addictions to measuring lactate, and that maybe the lactate clearance over time may be good parameter, but then hence it may also be not. The guidelines state to combine antibiotic treatment, and this is a very strong recommendation, but the quality of evidence behind the statement is very low. And if we then have a look at the recommendation for fluid resuscitation, also here we read a strong recommendation but low quality of evidence regarding the 30 ml per kilo in the first 3 hours. So in fact there is no evidence at all. But over the years we have incorporated aggressive fluid resuscitation as a cornerstone in the treatment of shock, but without any evidence to support this. So that was 2016, was reconfirmed, and maybe this dates from the ages where there was the blue stage of spasmodic cholera, and much of our traditions in fluid resuscitation comes from the cholera experience where giving fluids saved lives. And this is kind of deeply ingrained in our culture that shock always equals hypovolemia, which may not always be the case. So in 2018, there was an update of the sepsis bundle, especially from the first 3 hours, which stated that now the fluids should be given in the first 1 hour, or at least started in the first 1 hour. So from the 3 hour bundle, we now have the 1 hour bundle with the 4 things that we already mentioned, and then the early application of vasopressors. So 30 ml per kilo in 1 hour, maybe this may lead to fluid overload, and there is this SEP1 mandate in the state of New York, as I alluded to, by Governor Cuomo, where it's mandatory to start or give 30 ml per kilo in 1 hour to every patient. So maybe this is complete and utter madness. Why is this? So if you would be a patient, a classic patient in the US, weighing 155 kilos, which means that you would need to start 4.5 liters in the first hour. If you don't do that and you live in the state of New York, you go to high court because of malpractice. And if you do that, you may end up with fluid overload, especially if there is kidney injury or heart failure. and you may also go to High Court. So another question is, where is the grade in these recommendations by the Surviving Sepsis Campaign Guideline? And a good friend, Paul Merrick, sent individual emails to the co-authors of the guidelines, whereas 62 responded that they did not agree with the 30 ml per kilo in 1 hour. So if you would follow the grade, by definition, if 20% do not agree, then you cannot give a recommendation. So the question is, where is the grade? So we do like bundles, and recently the goal-directed therapy was abandoned. Also the use of starches is abandoned. High chloride levels were abandoned. We don't use dopamine or phenylephrine, and we don't use deep sedation. But what about the bundles? And maybe Alice is not in Wonderland, but is lost in Bundleland. Because if we look at the first 1 or 3 hours, whatever, strong recommendation, low quality of evidence. And within the first 6 hours, there is strong recommendation, but low quality of evidence. So what is the best that you can get if you sum up all these low quality of evidence? This is the advertisement for Gillette. So the best you can get is a strong recommendation and low quality of evidence. Next comes that correlations that we find in the literature may not be associations, nor may they be causations. And in this study by Seymour, published in the New England Journal of Medicine, looking at the time to treatment and mortality in patients with sepsis, you can see that the time to complete the 3-hour bundle was associated with in-hospital mortality, as was the time, the delay in antibiotics. But funny, there was no difference in the time to complete the fluid resuscitation. Other studies, a landmark paper by Kumar, shows a very strange linear correlation between the delay in providing antibiotics and survival. But I think that Mervyn will discuss this. So, say what? Well, just to rephrase Mervyn, he calls this incestuous amplification. It's a very difficult word, but it's the extreme reinforcement of ideas and beliefs that occurs when like-minded people communicate with each other. And this may be the case, what happened with the guidelines or bundles. Because every patient is an individual and may need individual treatments. One size does not fit all. So I see you all wondering, so then what is the solution? And that's for the next speakers. But I think that every patient deserves an individualized, personalized treatment where we set the targets right and adapt the targets over the time course in order to reach the goals. The ultimate goal is to save the patient by avoiding fluid overload and by avoiding antimicrobial resistance. So for me, retirement for the guidelines is just ahead. And when we asked the question on Twitter, the majority of colleagues that are on Twitter don't adhere to the guidelines, nor do they support the guidelines. And one of the co-authors of the latest revision of the guidelines, which is Tiffany Osborne, she was unaware of the 2018 bundle update, which for emergency physicians make a hell of a lot of a difference, because within the first hour, when the patient is in the ER, you need to do a lot of things. And because of all of this fuss, the Society of Critical Care Medicine and the American College of Emergency Physicians last year recommended that hospitals should not implement the 1-hour bundle in its present form. So this would be all what I would like to share. The known knowns is that we know that sepsis is a syndrome and it is very complex. The known unknowns are that we don't know who to treat, when to treat, how to treat. But if you look at the unknown knowns, we may not have a clue, but I think it may be time to reduce antibiotic burden, and that's Professor Singer. And maybe it's time to start therapeutic drug monitoring for Professor De Waal. the unknown unknowns. That's what research is for. With that, I would like to extend an invitation to join us in Valencia for the next Fluid Academy Day. If it's too far away, you can also follow the live stream. Thank you for your attention. So now we'll have the discussion at the end. So Professor Singer is an adept for Mac and Keynote, and you will quickly understand how that comes.
Thank you.
So it's my pleasure to introduce Professor Mervyn Singer. I think we go a long time, and he's from London, UK. Still now before the Brexit. It was very easy to get here, and I hope it will be very easy to get back to the UK. And we're thrilled to hear everything about reducing antibiotic use. Could you use the mic for...
Thank you very much indeed. Manu, thank you. Lovely to be here. Thank you. Thank you, Manu, Matthias, for the invitation. So I'll hopefully be gently provocative about antibiotics. Hopefully I can persuade you to agree with me. But let's see. Okay. So why the fuss? Well, I think there are a number of reasons. We have a balancing act. So clearly, you know, antibiotics are an important part of our therapeutic armamentarium for dealing with infection. But on the other hand, they're quite nasty drugs. They carry multiple side effects, which often we're not aware of at the end of the bed, and they can often cause quite significant damage. Here's a list of the evil side. So we see the rashes, the hepatic dysfunction, the renal dysfunction. We're aware of the overgrowth of multi-drug resistant bacteria, Clostridium difficile, fungi. But did you know antibiotics are immunosuppressive? They compromise mitochondrial function. And again, there's quite an animal literature, there's some human data to show, especially when you give a bactericidal that explodes the bacteria and destroys the cell wall, that releases bacterial products and stimulates the inflammatory response. That might be my email, but going ding, so I apologise. I'll turn it off if it carries on dinging. But that's a Jarisch-Herxheimer response, first seen with treatment for, you know, anti or metal agents for syphilis, but being described for parasite treatment and for treating bacteria. We're becoming more aware of the importance of the microbiome. I'll touch on that briefly later, and I'll also touch upon the effects of antibiotics on cancer therapy. This came out from Sarah Cosgrove, who's an infectious disease doctor in the States, a couple of years ago, and they looked at patients who developed complications related to antibiotics. 20% of patients who received an antibiotic in hospital experienced at least one adverse drug event. And 20% of patients who didn't have a clinical indication for an antibiotic but were still given the antibiotic also suffered an adverse event, including 7 cases of Clostridium difficile. So we're giving a problem with an unnecessary treatment. And so there are, there's a few little underlines. So if you go to the World Health Organization, they comment on over-prescribing of antibiotics, but actually I disagree. Patients not finishing their treatment. So I'll touch later on how long should a treatment course be. But look, we are getting worse. We're throwing around antibiotics and the problem's increasing. So this is the EARS network looking at resistance across Europe. I've just picked Klebsiella, and these are the isolates with combined resistance to fluoroquinolones, third-generation cephalosporins, and aminoglycosides. And hey, I'm in Belgium. So there you are there in 2011 in light green, sort of 1 to 5% resistance. Now you've become yellow, 5 to 10% resistance. So you're getting worse. Thankfully, the UK is still light green, yes, and as you know, and Scandinavia, but it is a problem. Look at Eastern Europe, look at Southern Europe. Houston, we have a big problem. And if we carry on the rate we're going, we will struggle to use antibiotics for anybody because we're going to have a huge issue with resistance and nothing left to offer the patient. The microbiome, I think, is fascinating, and there's lots of data now showing effects of antibiotics, and literally a couple of doses, even one dose, you knock out a large amount of the normal flora and the diversity, and you get overgrowth, often of sort of enterococcus, for example. This is a fascinating French study. There's been a British paper that's essentially replicated this. But patients receiving therapy for different, like lung cancer, etc., renal cell cancer, get checkpoint inhibitors, PD-1 inhibitors. And you can see here, if you got an antibiotic during the course of your cancer therapy, the outcome was significantly worse. And many of these antibiotics were just oral antibiotics given by the family practitioner for a, inverted commas, a chest infection or a urinary infection. But look there, the mortality rate significantly worse. And why? Well, it's a very elegant study, and they found that the antibiotics took out specific bugs in the gut flora, and they focused on something called Akkermansia mucinophilia, which I'd never heard of before I read this paper. And they replicated this in a mouse model of a tumour growth. And you can see that if you gave the PD-1 inhibitor, I'll walk over here, I've got no pointer, or you didn't give it, the tumour was growing quite well. If you basically, all of these had antibiotics. If you gave it, it shrank a bit, but if you added the Akkermansia, there was a significant benefit. So basically, the antibiotic therapy took out healthy microbiota, which some mechanism for making the cancer therapy more effective. And even long-term outcomes, again, this isn't over days, this is over months, looking at post-transplantation. And patients who'd received a course of antibiotics did much worse in the long term, and we're talking over 90-odd months, if they'd received antibiotics during their treatment. They gave reasons why. So coming to the title topic, strategies for reducing antibiotic use. Clearly, don't start. Or perhaps don't rush in unless necessary. The second option is stop quickly. The third option is, do we need to throw around combination therapies unless there's a good reason to do so? So let's just go through each of these. Don't start or don't rush in. So you've heard the propaganda, every hour's antibiotic delay costs lives. However, when you look at the evidence, it's all based on retrospective analyses of databases often collected for other reasons. There's often very heavy statistical adjustments. The crude mortality doesn't show an effect, but you need to adjust statistically to make your point. There's a lot of missing data. Did the patients actually have an infection? What was source control like? Was the antibiotic therapy appropriate for the type of infection? We don't know. And I'll give you a few examples in the next few slides, but there's lots of biological or clinical implausibilities that should make us question the accuracy of the statements. Every prospective study I'm aware of looking specifically at time to antibiotic and outcome has not shown benefit. And there are before-after studies. I'll show you one randomized controlled trial from the Netherlands, and there are two large multi-center quality improvement programs, one from Spain, one from Germany, with big advocates of surviving sepsis, etc., who couldn't show a benefit. Manu mentioned the Seymour paper. So we heard about the New York mandate, And essentially, this paper looked at the database and looked at patients who came into New York State hospitals before and after, after the mandate. And they concluded more rapid completion of this bundle of care related to rapid administration of antibiotics, but not, as Manu showed you, rapid completion of fluid were associated with a lower risk-adjusted in-hospital mortality. But let's dissect this a little bit, because you get the Twitter feeds, people read the abstract of the paper, but do you actually read the detail? And often the devil is in the detail. So here, nearly 50,000 patients, 41,000, 82.5%, had the 3-hour bundle completed within 3 hours. So hang on, if it was mandated, another email, sorry. If it was mandated, why didn't the 17.5% who didn't get it, why not? We don't know. And there are lots of potential explanations. Often these are elderly, frail patients who don't present in a classical manner. And again, if you look at the results, a longer time to the completion of the bundle was associated with higher risk-adjusted in-hospital mortality. As I'll show you, it's not real mortality, it's risk adjustment, and there's a lot of risk adjustment. And it's 4% per hour, as was a longer time to the administration of antibiotics, 4% per hour. However, this isn't a 4% increased risk of dying, it's a 4% increase in the risk of dying. You understand? So say you've got a 25% mortality rate, a 4% increased risk of dying is 1%, it's not 4%. So it's a risk of that 25%. So it's a much lower risk, but the way it's portrayed, every hour, 4% increased risk of dying. But it's an increase in the risk of dying, but it's not even the risk of real dying, it's the risk of risk-adjusted dying. Do you follow me? It's a little bit contrived, but perhaps it wasn't necessarily clear to people who either read it or necessarily listened to my explanation. But when you look at the real mortality, there was only a 1% difference, absolute mortality. Again, we don't know why the patients who had this delayed treatment were delayed, despite it being mandated. And again, lots of other oddities. I'll just pick on a few. You'd think if the patient's getting an antibacterial, then those patients with a proven bacteremia would benefit. But as you see here, gram-positive bacteremia, 7,000 patients, no benefit. There was a benefit from gram-negative, a benefit where they couldn't find an organism. We don't know if they were even infected or not. And the biggest benefit, 15% risk of dying, or risk-adjusted dying, was in other. And other was anaerobic mixed viral, fungal, and yeast. And I don't know about you, but my microbiology tells me an antibacterial won't generally be effective for most of these infections. But that was where the biggest outcome was achieved. And as I mentioned earlier, we've got lots of missing data. The final thing I'll show you on this paper was, again, if you look at the patients, 2/3 of them who weren't given a vasopressor, no benefit. So the benefit was only seen in those patients who were, in inverted commas, shocked, but at least they were hypotensive and given a vasopressor. Okay, but is there a risk? If we don't rush in with our treatment, will these patients result or progress to getting septic shock if they aren't in shock to begin with? So again, Steve Simpson, who's again another big advocate of surviving sepsis, came out with this paper, and if you read the conclusion, this study emphasizes the importance of early broad-spectrum antimicrobial administration in severe sepsis in patients coming through the emergency department. Longer time to antimicrobial administration is associated with increased progression of severe sepsis, now we call it sepsis, to septic shock and then increased mortality. But if you read the paper and look at the figure, let's draw a line at 5 hours. And as you can see here, the proportion progressing to septic shock is pretty flat over that 5-hour period. It only jumps up later on, especially if there's a delay in starting antibiotics of 18 to 24 hours. So again, the way the conclusion is phrased doesn't quite represent the time aspects of this figure. Okay, what about a few prospective studies? I won't go through them in any great detail because there are loads, but this is, I mentioned one from the Netherlands. This was pre-hospital antibiotics versus starting in the emergency department. So nearly 2,700 patients. The paramedics gave the antibiotics on average 26 minutes, time to antibiotics, 26 minutes before arrival in the emergency department. The standard care group received on average the antibiotics at 70 minutes after arrival. So there was a difference of 96 minutes. And as you can see, in terms of the quick SOFA score or the severity of sepsis, there was no difference. That 96 minutes made no difference to the outcome of the patient. I'll show you this weird study. It's a fascinating study. It got NIH funded in America. It was ethics committee approved in the University of Virginia Medical Center. It was in the surgical ICU. And they argued, well, let's not give antibiotics unless we have a proven infection. So unless the microbiology department grows something or bugs are identified in a normally sterile fluid, let's hold off. And it was a before-after study. So in the first year, then normal practice. The second year, a more conservative approach. So you had about 240 patients each year, and apparently their practices were otherwise unchanged. You can see here the time to starting treatment was significantly delayed in the second year when they waited for the microbiology lab to identify a problem. The duration of antibiotics, which may be relevant, was the mean was significantly shorter. And if you look at mortality, interestingly, those treated conservatively had half the mortality rate of those who had aggressive treatment. Not quite what you'd expect. And even in the patients who had hypotension at the time the infection was queried, there were about 100 in each group. The time, there was median from 4 hours to 20 hours, so there was a 16-hour gap. And as you can see, the mortality was very different in favor of wait and see. Now, I'm not advocating don't give antibiotics. Probably if I was very sick, I'd want an antibiotic early. But it's interesting that their findings contradicted the current dogma. The Infectious Disease Society of America didn't agree with surviving sepsis because they felt, like me, that the data wasn't good enough to support the argument. Yes, if the patient's very sick, it's reasonable to then initiate quickly. However, stipulating this aggressive time period from the time of recognition with the clock ticking may lead to unintended consequences. They focused on antimicrobial resistance, but I've shown you a whole load of other problems that we don't see at the end of the bed. And they also make the point that sometimes in the rush to treat these patients, we badge them as infected, whereas they may have another issue. This is a paper from Alan Jones, who's in North Carolina, an emergency physician. 211 patients who were initially suspected of having sepsis. 37 turned out to have a non-infectious diagnosis. 19 they weren't certain of. And again, in my practice, I've seen a whole load of non-infectious conditions which have been initially badge treated as sepsis. This is from the Netherlands, Utrecht and AMC in Amsterdam, the university hospitals there, and they collected data on patients admitted to their ICUs over a 2-year period, or nearly 3 years, and a few days later, when the results were in, they got clinical adjudication, knowing the microbiology data, etc., and basically, of nearly 2,600 patients, 13% had a post hoc infection likelihood of none. It turned out to be something else. A further 30% only possible. So probable and definite only accounted for just over half the patients. So it's unlikely that the antibiotic will have any benefit in a patient who doesn't have a bacterial infection. And I wrote this editorial last year, and basically it's just reaching a balance, a nuanced approach. We shouldn't have, and I think echoing what Manu's point is, we shouldn't just adopt a one-size-fits-all attitude. We need to have a nuanced approach to treating patients. So clearly, the sicker the patient, the more aggressive you can be, and how certain you are about the diagnosis, rather than just rushing to treat every patient. So I think it's reasonable in those patients who are in shock, in those patients who are rapidly deteriorating, it's reasonable to jump. Whether it works or not, I don't know, but I think intuitively it seems like we're doing the right thing. And clearly, once you've decided to give an antibiotic, there's no reason for a logistic delay. If you decided, hopefully you, the clinician, the nurse, etc., should be giving that antibiotic promptly once you've made that decision. However, in the less sick, especially in those where you've got a lot of diagnostic uncertainty, I don't think you need to rush in. You've got time to do some tests, to consider, to look for other diagnoses, and then make that considered decision. Do they have a bacterial infection that I need to treat, or could it be something else? Viral or whatever, or non-infectious. So I have this little schema, the certainty of bacterial infection on the y-axis and illness severity along the x-axis. So clearly, if the patient's really ill, I think it's reasonable to jump in quickly. If they're not ill and you don't think it's infection, then, or there's a very low risk, then you can watch, wait, do some tests, look at the patient's clinical progression. On the other hand, they're not sick, but you're pretty sure it's a bacterial infection. Again, it doesn't mean you need to rush in with an antibiotic. Often it's a case of taking out an infected line, for example, or an infected catheter without necessarily putting them on an antibiotic. So again, you've got time to think about the best treatment, but avoiding unnecessary logistical delay. And clearly those where you're worried, you know, they're ill, they're very ill, they could have an infection, then I think it's reasonable to start treating those patients. And then if in a day or two's time it evolves that it's actually not infection, it's something else, then you can rationalize and stop the antibiotic. Okay, how long should a course of antibiotics be? Okay, the patient has meningococcal meningitis. A darkened room, but I'll ask for a show of hands. Who would give 1 day's treatment? Nobody. 3 days? Nobody's raising their hands. 5. 1 hand, Jan, and 2, Manu. So the front row are voting for 5. 7. A few more hands. 10 to 14. A few hands. More than 14. So we've got about 7 days. What does the literature show? Here, this is a large multi-center study in children, non-neonates, but looked at 5 versus 10 days, and basically mortality and relapse identical, whether they got 10 days or 5 days. And survival with sequelae, no difference. This came out in The Lancet, 2011. And they argued the antibiotic can be safely discontinued in those who are stable, whether they had pneumococcus, Haemophilus, or meningococcus. What about 3 days? New Zealand, so it's not a randomized trial, but their practice that they've reported on is just to give 3 days of treatment. And here they reported on 58 patients who were over 15 years of age, 20-odd% had septic shock, a further 10% had organ dysfunction outside the meninges, and they gave benzylpenicillin for 3 days. And basically, they found that was good enough. No patients relapsed, 5 died, but all but one of these deaths occurred during that 3-day treatment course, and the only post-treatment death was not related to the meningococcus. So they argued that perhaps that's all you need, 3 days. The usual recommendations perhaps are excessive. But that's 3 days. What about 1 day? This Lancet paper was 1 dose of ceftriaxone given in a clinic in Niger. And if you look down there, death at 72 hours, very low, with just 1 dose. Only a small number needed a second injection between 1 and 2 days, and neurological sequelae, again, very similar between the groups. So I'm not necessarily saying just give 1 dose, but again, there's a literature out there showing it seemed to be effective. Even in Niger, where they can't, unfortunately, do a lot of what we hold dear in richer societies. Okay, next question, peritonitis. You've got the surgeon to give you adequate source control. Who'd give a day's antibiotic treatment afterwards? No, nobody. 3 days. 5? A couple of hands. 7? A few more hands. 10 to 14? A couple of hands. More than 14. Okay. Large American trial, multi-center. 4 versus 8 days after adequate source control. No difference in outcomes. So again, provided you have good source control, antibiotics don't work very well when there's pus. So provided you've got source control, 4 days in this population was good enough. And as you see, there's 500 patients in the study. VAP, ventilator-associated pneumonia. Who'd go for 1 day? 3? 5? Quite a few hands. 7? A few hands. 10 to 14? I think 1 hand I saw. More than 14. Okay, this is from Jean Chastre in Paris, where 8 was the same as 15. There hadn't, to my knowledge, been shorter trials. But essentially, they noted that if you gave the shorter course, multi-resistant pathogens emerged less frequently. My practice, I give 4 or 5 days, sometimes even shorter. Again, if the patient's getting better, I'll stop a day later. Usually, again, philosophically, if the patient has improved with the antibiotic, they're going to improve quickly. So unless you've got a deep-seated problem, an osteomyelitis or some bug like TB, whatever, that you need a prolonged course, I would argue the vast majority of what we treat, you'll see a response fairly quickly if the antibiotic's going to work, and then you don't need to continue the antibiotic much beyond that. What about Staph aureus? This is where I have battles with my microbiologists. We have a very good relationship, and they come daily to the ICU, except Sundays. Bugs don't grow on a Sunday. But they're paranoid about Staph aureus bacteremia. So how long do you need to treat for? 1 day? So you've taken out the line or whatever's infected. 1 day? 3? Nobody? Oh, there's 1 hand maybe going up. 5? Couple of hands. 7? 10 to 14? More than 14. Okay, so we're averaging around 7 to 10 to 14. Again, this study came out, it's quite old, 276 patients, and this was with line-associated Staph aureus bacteremia, and they didn't find any relationship between the duration of treatment and the rate of relapse. And that was whether you cut the threshold at 7 days, 10 days, 14 days, etc. And they find there's other literature also that's out there supporting the fact that the duration of therapy doesn't relate to the risk of relapse. And they suggested that in most patients who have uncomplicated bacteremia, yep, you might go on longer for an osteomyelitis or an endocarditis or whatever, you don't normally need to give a long duration of treatment. Final bit, do we need to throw combination therapies at the patient? So by combination therapy, I mean 2 antibiotics directed at the same organism. The idea is you get synergism. Again, from this nice consortium done in Amsterdam and Utrecht, the MARS consortium, they published this recently, looking at patients, one of the hospitals routinely gave gentamicin for suspected gram-negatives, the other didn't. So you had a natural experiment, and all other things were essentially fairly equal between the two units. But as you can see, there was no benefit, in fact, a slight trend to harm in those who got the additional aminoglycoside, and they actually found both crude and adjusted analyses, the primary outcome, which is renal failure-free days, it was worse in those who got the gentamicin. And as you can see, it wasn't significant. There was a trend in terms of shock-free days and death. So again, there wasn't any signal to benefit by adding in an aminoglycoside, and perhaps a signal in the other direction. This is an interesting study. If you follow guidelines, look what happened. So Dan Kett works in Miami, and he looked at 4 ICUs in the US, looking at 303 patients at risk of developing a multi-drug resistant community hospital or ventilator-acquired pneumonia. And the guidelines from the Infectious Disease Society of America, the American Thoracic Society, suggested in these patients who are at risk, they needed dual cover for the gram-negatives and cover for MRSA, a gram-positive. And when they looked at it, you know, they wanted to see if you didn't follow the guidelines, did patients do badly? And on average, about 85% were compliant or non-compliant in terms of active empiric cover. But look at the survival. It was significantly worse if you followed the guidelines. So could it be that the antibiotic itself is causing harm? We're assuming they're good guys, but as I showed you right at the beginning, there is an association with harm. And perhaps we don't recognize it because the patient's sick, and it's easy to blame the patient. It's never our fault the patient dies. It's always the poor protoplasm of the patient. This came from Jose Garnacho Montero. He works in the south of Spain. And they looked at de-escalation of therapy, and there was an association, so it doesn't prove cause and effect, but there was an association with lower mortality. So ICU mortality, if you didn't change the antibiotic, 28% died. If you de-escalated, it fell to 24%. If you escalated, presumably the patients weren't responding, then it went up to 39%. And that relationship held true both in hospital mortality and 90-day mortality. So again, it may reflect the fact that the patients are getting better, or it may reflect the fact that a contribution, a negative, harmful contribution, may be caused by the antibiotic. I think this is my last data slide. So am I as good as my word? Well, we need to repeat it soon, but we reported on 2000 on our antibiotic practice, and again in 2013, and we have we're a mixed medical surgical ICU, we have a very large hem-oncology population. And approximately 2 in 3 of our patients got monotherapy for a median duration of 4 to 5 days. Those who got combination therapy, usually because there was some complex infection problem, they generally had a longer duration. But we had a very low rate of relapse and breakthrough, even with this short course therapy. And we had a very low rate of resistance, gram-positive, gram-negative, and actually I was talking earlier, we see very, very little fungus, even with a large hem-oncology population, because we give short courses. So, in summary, I think antibiotics represent an important part of our treatment. So don't get me wrong, give an antibiotic if the patient's very sick, but think how we should use it. The positive benefits may be offset by the unrecognized harms that these antibiotics are also causing. So please use them appropriately but sparingly, and not for too long. And on that note, I'll finish. Thank you very much for listening.
Thank you, Mervyn, for this excellent lecture. I would like to ask you to keep the questions for after the next speaker. So it's a pleasure to introduce you Jan de Waele. Don't follow the stairs. So Jan de Waele is working as a surgeon and intensive care worker, post-surgeon, but as an intensive care worker in the ICU in the Universal Hospital of Ghent. And he will give us a nice lecture on the use of TDM in antibiotic treatment. So Jan, I give the word to you.
Okay, thank you, Matthias. Indeed, again, just to clarify, I used to be a surgeon, but now I'm a surgical intensivist, yes. Thank you, first of all, of course, for having me here. It's a pleasure and an honor to speak about the important topic of therapeutic drug monitoring of antibiotics and whether we are ready to use it. Now, just to be clear, I will be mostly focusing on TDM of beta-lactam antibiotics. I think this is the most hot topic today. Of course, we've been monitoring glycopeptides and aminoglycosides for a long time, although many of the things I'm about to say probably also apply to these other drugs. Now, of course, the disclosures are important, as Manu already mentioned. This was the feeling when I heard I had to speak after Mervyn Singer. Slightly anxious, not sure if there will be anything left to discuss that's not been completely torn apart. But I'm very happy that Mervyn did not cover antibiotic TDM. So let's see what I have in store for you. These are the different topics I would like to discuss. And I will say right away that I will be very critical. Of course, I have to, again. Speaking after Mervyn would be kind of heresy, I think, to be not critical at all. So, what is the reason why we want to do TDM? Is it just because we like numbers? Probably. We do have to admit that we like to quantify stuff, especially stuff that we don't really understand. So let's maybe drill down first into what determines the efficacy of an antibiotic. There's three major players. There's, of course, the microorganism, although we should say that at the beginning of the treatment, we have no clue what the pathogen is in the majority of the situations, and it'll take at least one day, and often 2 or 3 days before we know what we're dealing with and what the susceptibility is. The host is also very important, of course, and the way the drug that we are administering behaves in the host, in the patient, is something that we've learned a lot about in the past few years. And the only thing that we're really sure about is the drug. We know what we are giving. We know how the drug actually kills the pathogen. So that's the strategy here is to use the characteristics of the drug to overcome the problems of the pharmacokinetics in the host. And these changes are multiple, and this is just an overview of all the things that are happening in our patients and that can either lead to an increased or a decreased concentration. And the increased cardiac output with increased clearance through the kidneys, increased volume of distributions, all things contributing to lower than expected concentrations of antibiotics. And on the other side of the spectrum, when we have dysfunction of organs, kidneys mainly, but also other organs, the liver, depending on the antibiotic you're giving, you'll have increased plasma concentrations of the drug. And when we then hook up a patient to an extracorporeal circuit or do other interventions, we are again changing the pharmacokinetics of the drug in a patient. So the bottom line is that in a lot of patients, actually, we have no clue what is happening. And this is where TDM comes in as a logical solution. Well, if we have no clue, let's just measure it. Is this concentration important? Because that's, of course, also a very important question. And probably it is. There's quite a lot of evidence showing that, first of all, there's a lot of variation in concentrations of beta-lactam antibiotics in this case. This comes from the DALI study. It was a point prevalence study looking at different beta-lactam antibiotics, and here you can see actually the variability of concentrations that you get. I'm trying to activate a pointer here, but it doesn't really show on the screen. Well, I see the pointer, you don't. Let me just show you that this is the range of antibiotic concentrations, mid-dose and end of dose. So it's not only about the fact that a lot of the patients do not get concentrations, high concentrations throughout the treatment, but also that it's highly variable. And one patient, when you're treating a patient with piperacillin and tazobactam, for instance, one patient may have 1 or 2 milligrams per liter, and another may have as much as 150. More importantly, it's what this study found actually, that 1 out of 6 patients doesn't reach the minimum target that there's consensus on that patients should get to have any antibiotic activity in the body. So it's really an important problem. So why do we want to optimize antibiotic treatment? Why do we want to change perfusions, change doses maybe, and also measure the concentration? Well, to compensate for this changed pharmacokinetics and the failure to reach the targets. Of course, we also want to maximize the eradication of the pathogen, maybe also at the same time prevent resistance development. Of course, we're in Belgium, a logical solution is just to give more drug, give higher concentrations. The thing is, it does help, but it's not the only solution. And this is why in the past 20 years, pharmacokinetic modeling has been extensively studied, pharmacokinetic modeling of different antibiotics, and particularly beta-lactam antibiotics. Now, there's a few issues with these PK models, and I'll go through them with you. You need to know that often these PK models and the development is based on small numbers. A lot of studies will have maybe 5, 10, 15 patients at most. It's quite a complex methodology. And more importantly, when we try to translate it to the clinic, is that it's actually not very good at predicting actual concentrations in individual patients. So it gives you an idea of what the main determinants are and how it will work for a population, but it's imperfect at the patient level, although it's on average better than what we do standard, so it's superior to standard dosing, no doubt. So when we look at, for instance, this study from Fabio Taccone, a few kilometers down the road, looking some time ago at the percentage of patients that reaches adequate pharmacokinetic targets, this is what you get. Now, very important here also to realize is that you need to be aware what targets we're discussing. I'll come back to that in a minute, but depending on the target you choose, you may have 100% or maybe like 20% target attainment. So always when you see these figures, just have a look at what it actually says. Now, what pharmacokinetic modeling learned us or gives us is this kind of prediction. This is the probability of target attainment when you give a certain antibiotic at a certain dose using a certain infusion strategy. Here, for instance, it's an imipenem, and you can use either intermittent bolus of 0.5 gram or 1 gram every 8 hours, or continuous infusion. And this kind of figure shows you, based on a particular MIC of a pathogen, this is the probability that I will reach a certain concentration, and this is often used to guide empirical dosing for a particular pathogen. The question, of course, is if we really can be very happy with this. Is this really the solution that we have been waiting for? So we need to question how good these models are, and this is done by comparing the prediction with an actually measured concentration. This is quite a complex figure, and it gives you actually 8 pharmacokinetic models predicting piperacillin concentrations in ICU patients, right? And it shows you how much actually the measured concentration deviates from the predicted concentration. And you can see, so on the y-axis, it's 100 to 200% deviation of the measured concentration. And you can see that all these pharmacokinetic models, a lot of them up to 100 or 200% deviation. So quite often the pharmacokinetic models have it wrong at the patient level. And this is even more true. This is a study we recently did in continuous infusion, but basically the same. Pharmacokinetic models are not very good at predicting concentrations, particularly if you use pharmacokinetic models that are developed out of data coming from intermittent infusion. You can just not blindly translate them to patients receiving continuous infusion. So a lot of issues there. Small numbers, interesting for empirical dosing. So how does TDM fit in this whole PK/PD optimized approach that we are pursuing? And the empirical dosing, of course, you cannot measure anything if you haven't given anything, and this is probably where pharmacokinetic modeling can play a role to better inform the empirical dosing, whereas TDM may play a role for this optimized maintenance dose, and hopefully in all our patients it will lead to clinical cure. The question is, of course, how, I mean, this sounds good, this looks good, this is intuitively the right way to do it, but how do we translate it in clinical practice? And there's a few issues, a few hurdles that we still have to take. So therapeutic drug monitoring is essentially nothing new. We've been using it for a long time, most of the time in antiepileptic drugs or immunosuppressants, or in drugs with a very narrow therapeutic toxic index where we wanted to avoid toxicity. So that's been the mainstay of how we've been using TDM in the ICU and outside of the ICU. But clearly here we are using it for a different target. We want to use TDM for efficacy and not for toxicity, and that's a very important thing to consider. Now, the first and foremost question is, what should we be aiming for? Because if you measure something and you get a number back, well, you need to know which direction you want this number to go. Is it okay? Should it be higher? Should it be lower? So let's talk a few minutes about PK/PD indices and targets. And I'm sure you've seen this kind of slide before. This shows you a concentration time curve of an antibiotic, and that there's different type of antibiotics. Some of the antibiotics are concentration dependent, so this is where it is important to have a high concentration over MIC ratio, whereas others, such as beta-lactam antibiotics, are time dependent. So the idea is, as long as the concentration of the antibiotic is above a certain threshold, then you're good, your patient will get better, and the pathogen will be eliminated. And these are a number of targets. So first thing, so these are actually the indices, right? And this is the target you should aim for. So first choose an index and then choose a target. Now choosing an index, it's quite simple. That's been laid out. Beta-lactam antibiotics, it's a time-dependent antibiotic. But then the question is, how long should the concentration of the drug be above this MIC? And this is what you will find in the literature for the beta-lactam antibiotics on the left. And you can already see that there's quite a lot of uncertainty. There is some agreement on what it should be, what the minimum threshold is, like 40 to 60%, depending on the kind of beta-lactam. But for more severe infections and to get maximal eradication, we may need higher targets. So let's zoom in. But maybe a question to you, what do you think are these numbers based on? Has anybody got a clue? Where does it come from? Does it come from randomized controlled trials? Do you have a patient that looks like this? I don't think so, huh? Because this is where it comes from. No, I'm not giving you the complete truth. A lot of the evidence also comes from test tubes. So I have to admit, test tubes or animal experiments have informed what we are doing to the critically ill patients. And, well, this gives me kind of a, well, the sense of unease, even when I add then that we're actually discussing plasma concentrations, whereas the pathogen, well, sometimes the pathogen is in the plasma, but often the pathogen is in the lung. And then what you measure in the plasma will not be the concentration at the site of infection. Yet in the test tube, of course, well, there was no issues of penetration into the test tube or something. It was quite clear there. And something else we've been looking at recently in Ghent is if you change the administration of a drug, when you go from intermittent dosing to continuous infusion of a beta-lactam, can you just take the same concept? Can you take the same targets? Probably not, because once you go to continuous infusion, there's no longer a percentage of time above the MIC. It's just below or above the MIC, and the only added thing you can do is maybe say it has to be above 2 times or 3 times the MIC. But 30 or 40 or 50% time above MIC, when you're switched to continuous infusion, it just doesn't work anymore. A few words on MIC, and I am not a microbiologist, and if you want more details, I'm sure the microbiologist here will give you more information. I'm also sure that they will agree with me that we're probably overestimating the, not the importance, but the role of the number we get back from the lab. So the MIC is the quantification of the susceptibility of the pathogen. And theoretically, it's the concentration of the antibiotic that prevents visible growth. There's a few words important in this definition. There's some things we should know when you get an MIC back from the lab. First of all, it's determined in a test tube, essentially. It takes 18 hours, so anything that happens beyond 18 hours, it's not relevant anymore, although in our patients, of course, pathogens are around for longer than 18 hours. Standardized medium, standardized inoculum at a 34 to 37 degree temperature. The thing is, if you would do it again and again in the lab, you will have different results, and that's perfectly okay. And if you do the same test in another lab, you also have different results, and they'll be even bigger, right? And again, it's perfectly okay. Let me just show you how this works. This is a set of test tubes with different concentrations of the antibiotic. You can see it above the tubes in green. And then a standard inoculum is put in each one of these test tubes. And you can see at a certain point of time, here it's at 1.8, you can see that the test tube becomes turbid, and this is where there's visible growth, and this would be the MIC. Now, if your lab, your lab is perfectly allowed to be at least, to be one dilution off. So if it's 1.18, it could be 1/4 or 1/16, no problem at all. And this is also what the ISO certification, for instance, allows for. Because often when we, as a clinician, receive an MIC, we just feel it's a fixed number. It's, I mean, if we would get a CRP level back from the lab, that's like 100, and they would say, well, it could be 50, but it could be 200, I think we would be kind of confused and very unhappy with this uncertain result. But this is actually what is happening with the MIC. So I think we're a bit overestimating the role of the importance of the number, not of the test, but of the number. Please also note that visible growth probably occurs around 10 to the 7th. The inoculum is 10 to the 5th or 10 to the 6th. So there may be bacteriostasis or a little bit of growth that is not readily visible, and still the MIC will not reflect this. So many methodological problems, as I just alluded to, and it's difficult to translate it. Does it mean that it's completely useless? No, absolutely not. It's a measure of the activity of the drug against the pathogen you're dealing with, but it shouldn't be treated as a very accurate number. It gives you some idea whether it's very susceptible or less susceptible. But when we come back to the targets we're aiming for, the MIC is the denominator. So it's an important aspect to consider when we aim for a certain target. So how do we solve this? This is a paper 2 years ago from the late Johan Mouton and some colleagues who tried to solve this, and their conclusion was in case of wild-type susceptible pathogens, then the MIC, the target MIC, should be the epidemiological cutoff, assuming that even if it's very susceptible, higher concentrations will be sufficient to treat these pathogens. For the more resistant pathogens, it's problematic, and this is where these experts advised to aim for 2 dilutions higher. So if the MIC would be 1, then the target would be like 4, and MIC target would be 4. So this is kind of solved, but it's very important to realize that it's not a fixed number. So what about the assays we are using for TDM? This is a picture from our lab in Ghent. We want TDM, of course, we want it to be fast, we want it to be easy, stable in the pre-analytic phase, so it can be, it can stay around for maybe 1 or 2 hours and without any degradation. Validated methods, please. And okay, all of this may be true for instance, aminoglycosides and glycopeptides, but the situation is completely different for beta-lactam antibiotics. If you scan the literature, you will see there's a lot of in-house developed methods for not only meropenem piperacillin now, but a lot of the published methods actually are not as good as they claim. Also, these are okay for the blood, but it's not just so simple to just extrapolate and use these tests for instance, cerebrospinal fluid or peritoneal fluid or other matrices. I just want to share data that in the meantime have been published. This is about the stability in plasma. It's important to realize that the stability at room temperature of beta-lactams is very limited, and you should send these samples to the lab almost immediately, and they should be processed immediately. If you leave them around for a longer time, then you will have issues. So this is very important in the pre-analytical phase to make sure that the sample is correctly processed. Now, more importantly, and this is really worrying for me, and I think for a lot of people in this domain, this is a study we did in Belgium, where we sent the same samples to 5 different labs and had them all analyze the meropenem concentrations in this case. And here you can see that different runs in different centers give different results. So this concentration, for instance, of meropenem was as low as 5 milligrams per liter and could be up to 20. So these are the same samples sent to different centers. The conclusion of the study was that actually almost half of the meropenem and about 1 out of 4 of the piperacillin samples were measured inaccurately. So really there is some homework to do here when it comes to doing the accurate TDM. So there's no companies yet that have developed an immunoassay or similar. So still we need to rely on these HPLC methods. So what about clinical data? I realize that I haven't been very positive so far, but maybe, let's see, maybe the clinical data will be convincing. Of course, we want, Manu emphasized this at the beginning, that we need strong evidence before we implement something, but I can tell you that the evidence supporting TDM so far doesn't come anywhere near the 30 ml or any other thing you will read in the guideline. So what do we have? We have a lot of case reports or case series, often complex patients, often on ECMO or a lot of machinery, where the concentration was measured and it was found to be low, and the concentration was, the dose was increased, and the patient eventually got better. But this is, of course, not really a randomized controlled trial. Also a lot of data on multi-drug resistant infections, often from the south of Europe, where you then give like 12 grams of meropenem to treat an infection, and here again, the patient gets better. But maybe it's not just the concentration of the antibiotic. I think it's a little bit naive to assume that only the concentration of the antibiotic is relevant. I think the immune status of the patient is as relevant, the source control, and many other aspects. So this is kind of worrying, but, well, some people say, well, Jan, didn't you do a randomized trial on this? And indeed, we did. We did a randomized trial comparing standard of care versus TDM-guided therapy. Back in the time, we used 3-hour extended infusion of these drugs. The study was a small study and only aimed at confirming that TDM actually improves target attainment. Because if you do TDM and you're not able to increase target attainment, then you can't expect any clinical effect either. So this is what we did. We wanted to aim high, and these are the results, or part of the results. In the intervention group, 3 out of 4 patients required an intervention, so the concentration was not considered high enough. And after 3 days, indeed, target attainment was higher. But please note, this was the proportion of patients reaching 100% of the time above 1 times the MIC, so it was increased from 60% on average to 95. But our higher target, we were not able to reach it. Admittedly, the dose of piperacillin tazobactam was capped at 24 grams per day, because we felt it would be may be dangerous to give more than 24, going to 36 grams of 32 grams of pip-taz per day, and that's why we didn't do it. But it shows you on the one hand that yes, you can increase it, but in a lot of patients you may not even reach your target. This is another interesting study looking at TDM used on a daily basis in burn patients and carbapenems. Not a lot of infections, but what I just want to show you here is that maybe indeed at the first determination, about 1/3 of the patients had concentrations that were too low, but actually it required a second and even a third was not enough to get to the level desired. So you may have TDM, but it's not just about measuring, it's also what you do with the results. And if you don't know what to do with the results, if you don't have a proper dose adaptation scheme, then you will not get there. When I look at the literature, this is the only thing I can conclude. There is no evidence at all supporting the use of TDM, and I'm referring to a randomized trial where we compare a standard of care with a TDM-guided therapy. And of course, I know there is evidence that certain concentrations of antibiotics are linked to a better outcome. Right. And there is data that a lot of our patients do not reach these concentrations. But does that mean that when we get these patients that don't have adequate concentrations in the desired range, that their outcome will be better? I think we've been in that situation quite a few times. We measure the cortisol and we see, oh, the cortisol is not high enough, we need to give cortisone. But does it improve outcome? No. And it's the same for a lot of interventions that we've been doing. It's not because something is out of range that by pushing it back into the range, that automatically a miracle will happen and the patient will get better. So what now? There is a randomized controlled trial underway. So we can still be positive or end positive. This is a study that is ongoing in Germany. It's almost finished. You can read the protocol published in Trials some time ago. Pip-taz, 240 patients. I'm a little bit unhappy about these two things. TDM from Monday to Friday. It's like, you know, the bugs don't grow on a Sunday, and antibiotics are not to be measured on a Saturday and a Sunday either. The SOFA score and changes in the SOFA score is the primary endpoint. That never makes me happy. But again, well, we'll see. The thing that really makes me unhappy is this one. The standard dose is 13.5 grams. So that means 12 grams, 4.5, 3 times a day. There's a huge amount of evidence out there showing that with this dose, probably only 1 out of 4, 1 out of 5 patients will have adequate concentrations. So, mind you, it's continuous infusion. So this is why I've already given you the end result. I mean, this trial is not finished, so this is really my personal prediction as of today. Target attainment will be higher in TDM, of course, because it will be low in more than 70% of the patients. There's hundreds of patients that have been studied. And if you do TDM, probably it will be higher. And there will be a trend towards better outcome, yeah, because we are just underdosing patients. I mean, it's incredible still that these subtherapeutic doses of piperacillin and tazobactam are used in the ICU, I think, let alone in clinical trials that are supposed to prove the superiority of TDM. So a higher dose should have been used, and I can already say now that the results of this trial will be completely useless. So what to make out of this now? How should we proceed? Well, first of all, I hope I've shown you that doing TDM is not as simple as it seems. So superficially, yeah, okay, it's simple. Concentration needs to go higher, and the patient gets better. I think I've convinced you, and I've given you a lot of data showing that it's not that simple. But hey, well, you know, the thing is, TDM is a bit like this. It's new, it's shiny, it will bring something extra, and we all want it. The only thing is, we don't know how to drive it, probably. The majority will crash this thing within an hour, and that's just the same thing in TDM. TDM is attractive, it gives you a number, and even, I'm sure if it would come with a 15-inch screen with 16 million colors, it would be even more attractive, and everybody would want it more. But we need to look at the data. I think we need to get back to the drawing boards. We need to make sure that we get accurate assays, because I do believe that there's a role for TDM, but we just haven't figured out yet where and how to use it. And the danger is now, if we start just using it without any idea where we're going, in a few years' time, we will realize that it's a costly thing, and we will just throw it away. And again, it's comparable to a lot of other situations in critical care medicine. So better assays, we need to have clear targets for intermittent or continuous, and I'm very sure that they are not the same. And then we need to do these clinical studies that can actually have a chance of showing that an intervention is better. I just want to finish with clearly saying you that still it's a tool, and it should not, and it should be used not as an isolated thing. This fits in a broader strategy of PK/PD optimized therapy, and the German study I've shown you are a very clear example. If you're unable to do the basics right and do your standard dosing right, what's the use of doing TDM? It's completely useless. So where's the future? I think the future does look bright. I think we need also to evolve towards tissue concentration monitoring. We're working on analysis of the exhaled breath. And actually, I can tell you that you can measure concentrations of a drug in the exhaled breath of a patient. Rapid diagnostics, rapid TDM is what I'm referring to here. And why not have inline sensors showing you the concentration of a drug continuously? I don't think that's going to be very far away, and will probably revolutionize the way we treat these patients. And maybe also a role for data sciences. And big data may also help us to identify patients and maybe help us to predict concentrations in situations where you do not have TDM available. So let's get back to Mark Zuckerberg, because this is how Mark Zuckerberg looked like when he came to the European Commission last year to explain how Facebook will comply with the privacy laws. If I've left you a little bit looking like Mark Zuckerberg now, after all I've told you about TDM, then this is exactly where I wanted you to be. We need to realize that PKPD's strategies are important, and I'm sure that they will improve outcome. And TDM absolutely fits in this whole concept, and we need to move on and measure concentrations for efficacy. But there's just too many known unknowns. I've told you about the assays, the uncertainty about the target, and also the dose adaptation strategies. What we're doing now is just not good enough. Just doubling the dose or 50% increase or whatever we're doing now, it just doesn't work. But yes, absolutely, this can be part of our road to personalized antibiotic therapy. Just think we need to do our research better and make sure that what we do to our patients actually makes sense in order to avoid the 30 ml per kilogram mistake from the past. And with this, I would like to thank you for your attention, and I'm happy to take any questions.
Thank you, Jan, for this nice lecture. I think there will be some questions from the audience. For the two or for one of the two speakers, I will go with the mic.
Thank you, very interesting lecture. I have one question for both speakers. So I think your both presentations are a big cry for more practical guidance bedside, because the drugs work, but how to know when, in which patient, for who, how long. So what do you think will be the markers of the future or the approach of the future to have a better guidance to the use of those potent drugs?
So yes, if that carries on for a long
biomarkers is something you all hope for.
Yeah.
But until now, what we've had and all the biomarkers we've seen have not been able, particularly, to distinguish this infection from inflammation. And that's probably, from a clinical point of view, a very important thing. You need to use the mic for the right sound. Okay, so distinguishing between infection and inflammation is critical. I think we need to rely much more on clinical examination, something that a lot of people forget about, because biomarkers, they'll point you in the direction of inflammation mainly. The same thing with organ dysfunction. And this is one of the reasons why there's a lot of confusion about the use of the quick SOFA score, for instance, to diagnose infection. The SOFA score and quick SOFA score has nothing to do with infection. It's all markers of organ dysfunction related to inflammation, and this really defines sepsis. But diagnosing infection is something completely different. It's also completely ignored in the Surviving Sepsis campaign guidelines, for instance. This is not about diagnosing infection, and we need to more distinguish these two entities from each other. Biomarkers will not help us, I think, and rapid diagnostics, I think, will only lead to an explosion of using antibiotics, because it's not because there's a bacterium even found in the blood that it's a pathogen. How many of you have been bacteremic this week? All of you, assuming that you brush your teeth. When you brush your teeth, a lot of us get bacteremic, and if you would do a blood culture at that time, you will find some pathogens. And does it mean you need antibiotics? I assume most of you are here and you survived without any antibiotics. And that's just one example of how imperfect diagnostics, I mean, diagnostics used to be imperfect on the other side of the spectrum, that we're not able to identify everything, but now we'll be over-identifying stuff, and if you will be treating everything with antibiotics, then it's going to be much worse, I think.
Yeah, no, completely agree. There's a really nice study on similar lines to toothbrushing, but a group took blood cultures before and I think it was 15-30 minutes after percutaneous tracheostomy. And a percentage of the patients had a bacteremia in the post-blood culture, but not an immediate pre-percutaneous tracheostomy blood culture. But interestingly, what they found was, I can't remember how many, but there were quite a number of patients who were bacteremic in the pre-sample, but they were not clinically suspected of being infected. So again, there's probably a lot of asymptomatic bacteremia. Actually, let me throw a question at you guys. How many bacteria are in the blood in an average bacteremia? The microbiologists will hopefully know this. But how many bacteria are in a ml of blood? You've got 4 to 7 million white cells. How many bacteria to give you a bacteremia? Do you know what the average number is? How many colony-forming units in that ml where you've got 4 to 7 million white cells? Any of the microbiologists want to shout? The answer's somewhere between below 1 to 10 colony-forming units per ml. If you have an endocarditis, the bug's in the bloodstream, it can be in the hundreds, sometimes in the thousands. And that's why it takes the microbiology lab days to grow something sometimes, because there aren't many bugs there, and you've got to wait for the doubling for the lab to get excited. You know. So we treat bacteremia, but I would argue it's a biomarker, because in very few instances does a bacteremia, do you get, E. coli in the urine, you've got an E. coli bacteremia, that you get distant E. coli spread around the body. We don't see, by and large, much sort of secondary embolic spread of bacteria. So again, we're relying, I would argue, on an imperfect biomarker. We get very excited when the lab grows something. But again, and I think Jan made a very valid point, just because we're measuring something in the blood, a level, does that mean the same concentration will be at the tissue level where the bug is?
Again, I agree, Mervyn, that there's a lot of unknowns in this. And again, it's not because something is intuitively makes sense that we have to jump on the bandwagon. And it's again, I'm not against TDM. It's just I feel that we need to better study it before before routinely using it.
Are there questions?
Thank you for both lectures. It may be an oversimplification, but I'd still like to confront both speakers with each other. That from one hand, we heard that even 1 day of antibiotic may be enough. On the other hand, Professor De Waal is actually saying, well, not saying, but we have this Ferrari who actually was a Peugeot, but we have to look to this TDM and try to introduce it. So why bother if maybe 1 day of antibiotic treatment may be enough? So we have to keep our medicine a bit cheaper because it's already very expensive, and sometimes we are falling into the trap of over sophistication. So please may take this challenge.
I think you have a very good point there. It's all in a lot of TDM studies. You will see, I mean, not only beta-lactam but also other drugs. You will see that you will reach adequate concentrations 2, 3, 4 days down the road. But this is not what we want. We want to have adequate concentrations in the beginning in order to give brief therapy. Now, maybe, just maybe, of course, we need in some situations longer treatment because we've been dosing inadequately. And one of the remarkable things I always think is that if we discuss dosing, if we discuss duration of drugs, nobody mentions dosing. And the question is, what do you prefer? Do you prefer 3 days of adequate, highly dosed antibiotic treatment, or 7 days of just mediocre dosed antibiotics? Maybe they have the same clinical effect. And I think when we give short course therapy, dosing and dosing adequacy needs to be in the picture as well. But your point is well taken. Maybe it's better to give 2 days of high dose treatment. Then you can still use, of course, the whole strategy of PK/PD optimized treatment using the PK models that will inform you about how to dose adequately in the early phase. And for some treatments, maybe TDM is just not necessary.
As a quick comment to that, I partially agree, but partially disagree. My worry is that the high dose can cause toxicity. And therein, that's the trade-off, isn't it? That yes, I agree, giving a bigger dose will give you a bigger, a higher level, which should be more bactericidal, bacteriostatic, whatever you're using. However, there is the trade-off of toxicity, and again, it just worries me that we're ramping up doses, now of meropenem, quinolones, whatever, and yet the data isn't out there. Roberts, you showed a lot of Jason Roberts' stuff. His own efforts to show continuous infusions were better. He couldn't find it in his Bling study. And so if you can't find it, I think Bling 1 couldn't find it, Bling 2 couldn't find it. Let's do a bigger study, Bling 3, and see if we can show it in tens of thousands of patients. Go on.
I have to disagree on this one about the Bling studies. I mean, you're right, the evidence is not yet there, although there were trends, and when you do individual patient data meta-analysis, and then you do see some signal. The thing is, with our standard dosing, what we do now, and this is also something we know from the DALI study, that the highest concentrations currently we get at the end of the treatment. So I'm also worried about toxicity early on, but what we now have is the toxicity at day 7, at day 10, at day 14. And this is where you probably will not have any clinical effect on the pathogen anymore, but still have some toxicity there in our current dosing strategy.
So I have to interrupt because there are some questions from people following the live stream. The surgeons are mentioned, so one of the question is what they need to do if the surgeons want to blindly start meropenem for 3 weeks in pancreatitis. So how do we get the surgeons into this story? I also asked how many surgeons are following the live stream. I think there is none.
Okay,
there is one surgeon, 2 surgeons in the room. So how can we get them more involved?
Well, if a surgeon comes to you and wants to have 3 weeks of meropenem in a patient with pancreatitis without any demonstrated infection, then I think you need to find another surgeon. I think the evidence is clearly out there that there's no use of prophylactic antibiotics in this situation and many other situations. I mean, have them read the data, read the guidelines. If Manu, if you would allow them to read the guidelines, of course, then they'll find it there.
Yeah.
Okay, so we read the guidelines.
I very jokingly invite them to let me operate on the next patient. And they go, what do you mean? I say, well, you're telling me my job. Can I do your job, please? You know, and I think you're right. It's just show the data. The data doesn't show it. And in fact, you know, we have a fair amount of pancreatitis with our alcohol imbibing population. And again, we see very rarely fungal overgrowth in these patients. Why? Because we try and not give them antibiotics unless there's a clear need or concern that they have got superinfection of their phlegmon.
So there's a question regarding the high dose. So we give high dose because we're trying to reach the infected tissue. But then there's a question because of nephrologists who may want to limit the dose, give a low dose because they're afraid having too toxic levels. So what do we do with this?
Well, a bit of both things. I think the first dose you give of any antibiotic, of any drug, in a patient also with acute kidney injury or chronic kidney disease is irrespective of renal function. First dose is meant to saturate the volume of distribution, and the kidneys, of course, play a role, but in the elimination of a drug. So if the elimination is compromised, then you will give a reduced dose or you will increase the dosing interval. I think blindly, I mean, and my slide was jokingly about chocolate, but blindingly increasing the dose, I think is a stupid thing in many situations. We see a lot of patients coming in our unit now with 6 grams of meropenem being the standard dose for everything. But if there's one drug, at least in Belgium, where we have very little issues with underdosing at even 3 grams per day, it's meropenem, unless you're treating something really resistant. And just blindly increasing the dose for longer periods of time will indeed increase toxicity. And we're just assuming that beta-lactam antibiotics are not toxic, but I can assure you that at these higher doses, particularly in patients, in elderly patients with compromised organ function, you will get toxicity for sure.
Okay. So a question regarding the high doses for critically ill patients and long-term infusions, so 4 days. So how do we adjust it if you don't do the therapeutic drug monitoring? Any advice?
Well, my advice is use standard dosing and the highest range of what your package insert will say. Again, for instance, for Piptaz, I know there's still hospitals using 4 grams 3 times a day, but I think that should be a thing of the past. And 4 grams 4 times a day is the upper limit of normal dosing, normal package insert dosing. I think that's the strategy to use. In selected patients, particularly patients with augmented renal clearance, and we really didn't discuss this, you know in these patients that renal elimination will be enhanced and you will have lower concentrations. And maybe in these patients you can indeed safely go up to 20 to 24 grams per day. Sometimes we do it, but certainly not routinely. And I think the danger is in doing these blind dose increases as a standard strategy.
So a question regarding therapeutic drug monitoring during hemoperfusion with polymyxin B, cytosorb or high adsorptive membranes like the auxiliary membrane. Do you recommend to increase the antibiotic dosage in these scenarios?
Well, these are indeed difficult situations. It may be useful to do TDM just to assure that you have at least a minimal concentration of these drugs. I'm not aware of any studies supporting doing routinely TDM in these patients and adjusting the dose, although my experience is that in patients with acute kidney injury, they're usually put on antibiotics before renal replacement therapy or any other extracorporeal circuit is added to the treatment. In those patients who have been on antibiotics before any additional therapy, these concentrations will be high in the majority of them. And maybe if you continuously dialyze them for days, eventually the concentrations will drop. What we do in renal replacement treatment patients is just give a standard dose. So we rarely dose adjust during CRRT.
So We may take a question from the audience here and then go back to some questions from the live stream. Please take the microphone so that everyone can hear.
Good evening. My question is, how do you stand on the role of procalcitonin on the start or cessation of antibiotics?
Procalcitonin. So again, procalcitonin hasn't really taken off in the UK. So it started from Germany and spread its tentacles into France, I think Belgium, Italy, etc. Basically, the literature shows it's on a par with CRP, maybe a little bit better. Certainly as an early therapy, you know, it goes up after trauma, it goes up after surgery, etc. Should you use it as a guide as to when to stop treatment? Well, in fact, we're doing a large government-funded multi-centre trial in the UK at the moment of CRP versus procalcitonin versus nothing. And so the hospitals, have, you know, the ones participating have agreed, you know, in some cases to use nothing, just clinical gestalt as to when to stop the antibiotic. Interestingly, there have been a few studies where procalcitonin has actually prolonged the duration of antibiotics. There's a Danish study, and the outcomes were worse. So again, it's a double-edged sword. So I think, like all of these things, PCT, CRP, it tells you there's inflammation. But is that inflammation necessarily related to infection? And the point I was making earlier is that just because there's inflammation doesn't necessarily mean there's an ongoing infection. So I think we hold these things dear. A high white count, yes. But, you know, should we just treat a number, or yes, the CRP's high, but the patient's fine? You know, so my view is it's that combination of, yes, I look at the CRP, that's what we measure in our hospital, but look at the clinical condition of the patient. If they're getting better, I'll watch. If they're deteriorating, then, you know, that's the clue. I don't know if you want to add to that.
We don't have it in Ghent. I do think there's some value. I think the Dutch study and the Dutch situation is probably more comparable to our situation compared to some of the other studies where antibiotic therapy was 14 days or 2 weeks. In the Dutch study, the SAPS study, the duration was reduced from 7 to 5 days, which is, of course, nice. So it shows that it can make a difference. The question there, of course, being what will the effect be of, well, it wasn't completely 2 days, was 1.5 days, shorter duration of treatment. Will you get less resistance? Will you get less toxicity? I'm not sure about that. Maybe there's some value also in these patients where you want to wait with starting treatment, starting empirical treatment as well. It seems to me that the evidence is much stronger than for CRP. If you work in a hospital where the standard duration is 10, 12, 15 days, then probably it will be helpful to make significant impact.
I think my answer to that is it just a comfort blanket? Yeah, but then if you have the comfort in thinking, well, I'll just give 5 days regardless, you know, you don't need the test.
I fully agree. But clearly, we still use antibiotics for a long period of time. In the Diana study that we just finished, 1,500 patients in 28 countries, the average duration of antimicrobial therapy was 12 days. 12 days. Despite probably PCT in some centers and everything. So we just have to realize that despite what all the guidelines say, not everybody reads the complete guidelines or doesn't have the confidence. And maybe they have their surgeon breathing down their neck like, well, don't stop the antibiotics. I want you to continue them because this and that reason. Right. We also do have to realize that a lot of the studies done on PCT excluded many patients with more chronic infections, and there could be some selection bias there as well. It's the same comment I always have with the Sawyer study on intra-abdominal infections comparing 4 and 8 days. This is true, but we have to realize that, well, the mortality in the Sawyer study was 1%. So this is clearly not an ICU population, and I'm not sure if we can just extrapolate everything to an ICU setting. I don't know. That's the
Yes, I want to address some of the interactions. It's really fascinating. We have people from Brazil, from Morocco, people on holiday in Morocco, Egypt, Poland. So is a lot of. So some of the questions are a practical question. How many days of treatment for a septic shock patient with multi-drug resistant Klebsiella pneumoniae or Acinetobacter baumannii? How many days?
Again, my argument would be if they haven't got better in 4 or 5 days, there's no point continuing with that antibiotic. If you don't see a response fairly quickly, unless there's an abscess, then that antibiotic, just giving 10 days rather than 5, if you haven't got a clinical response, to my mind, there's no point continuing. So that's my clue. If an antibiotic works, you should see some benefit within 2-3 days.
Would you recommend 1 gram of meropenem in 3-hour infusion 8 times a day?
8 times a day?
8 times
Yes.
a day. That's
It's high dose.
Continuous.
That's continuous 8 grams per day. That would be quite a high dose, I think, and probably dangerous in a lot of patients.
Then there are some questions about antibiotic surgical prophylaxis. Can antibiotics be more dangerous than the benefit of the major surgery per se, like immunoparesis and these kind of things, than the role of CRP in anergic, cachectic patients with low white blood cell count and low lymphocytes?
What these questions show, actually, I think, is that there's always specific patient situations that you can imagine where all of this doesn't apply. So what we've been discussing, I think, is not a blanket strategy for every patient in your ICU and in the hospital. And in some situations, you do have to rely on clinical experience and monitor a patient. And if you see that a patient is not doing better, then of course question what is happening. Is it the drug that we've been giving in an inadequate dose? And for instance, in these multi-drug infections, one of the reasons why we've been continuing the antibiotic treatment for weeks often is because we don't know how to dose these old drugs. If we dose colistin, well, we basically have no clue what we're doing, and then we just continue. But finding a solution for each individual situation, I think that's going to be very hard, and that's still where the art of medicine comes into play, I think.
No, I agree.
Okay, I think we have to end up the session here. I will ask some 3 short questions with short answers, a little bit controversy. So what we do with the pathology of the aspiration pneumonia, often treated, should we treat or not?
Not routinely.
Not routinely.
Should we take in the emergency department and in the ICU routine urine cultures, and what do we do with the positive cultures?
No routine cultures.
Should we treat them?
Well, no routine cultures and no routine treatment. So again, if there's symptomaticity, and they've got clear evidence of a nephritis, that's a different story. But just doing routine cultures, when there's no history, I think the evidence, and clearly if you have an indwelling catheter, our labs in our hospital, the microbiology lab, will not process urine from a catheter if it's been in, because they say you'll always find white cells and you'll always find bugs.
Can I still slightly modify? Because we do cultures, but only because of surveillance reasons, so to identify colonizing pathogens. We've stopped a few years ago doing routinely urea analysis, so doing the white cell counts. So it used to be standard 10 years ago, but we stopped it, and we kind of miraculously reduced the number of urinary tract infections, or at least antibiotics given because of positive cultures and positive white blood cell counts.
And then the last question, escalation in antibiotic therapy, is it changing the antibiotics or increasing the dose?
For me, it's changing the antibiotics.
And when the treatment is not effective, should we try to increase the dose?
Well, that's a difficult one. If the patient fails clinically, and you know, for instance, that you're dealing with a hyperfiltrating patient, you could indeed increase the dose. Now, this is also where then the problem of the pharmacokinetics comes in. How are you going to do it? Are you going to go to 32 grams of piperacillin tazobactam per day? I mean, some colleagues may shoot you for this. so that's really a difficult one, because if you switch, for instance, to a carbapenem, still the same phenomenon may be there, and also you may have low carbapenem concentrations. So these hyperfiltrating patients, and they are a challenge, and sometimes you need just to start with a higher dose initially.
The other thing I'd add to that is ask, has the patient got an infection? Because I think often you look, I'll give you a very quick example. We had a patient, she had lots of lymphocytes in her CSF. She was under the IT team, and she was very agitated, confused, etc., etc. And she wasn't responding to antibiotics. Oh, should they add in more? Blah 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 blah. Could it be TB? And she was being treated for that. And I said she's not infected, and it turned out to be NMDA receptor encephalitis. So again, so challenge the fact, have they got an infection? And I think often you find, like, patients with a very high temperature, stop the antibiotic and the temperature goes away. So again, just because they're not responding, you shouldn't automatically assume it's an infection that's not responding.
Okay, I think...
One more thing, because this is an opportunity for me also to say that this is a nice example where you have to have a good antibiotic stewardship team. Because in this situation, you have to go to your microbiologist and discuss and look at the options, because by then you will know what pathogen we're dealing with, and then the microbiologist surely will give you some direction as to, like, well, I'm not surprised why this drug is not working perfectly, and you have other options as well. So all of this should be done in a stewardship, teamwork approach.
Okay, I would like to thank you all for your presence, and thank you and the live online watchers too.